Inspect the shoulders and shoulder girdle anteriorly, then the scapula and related muscles posteriorly. Note any swelling, deformity, muscle atrophy, or fasciculations. Look for swelling of the joint capsule anteriorly or bulge in the subarachnoid bursa under the deltoid muscle. Begin by palpating the bony contours and structures of the shoulder, then palpate any area of pain. For flexion, raise the patient arm in the front and over the head. For extension, raise the patient's arm behind them. For abduction, raise the patient's arm out to the side and over the head. For adduction, cross the patient's arm in front of their body. And for internal rotation, place the patient's hand behind their back and touch the shoulder blade. Elevate the patient's arm to 90 degrees flexion and adduct the patient's arm across the chest. Ask the patient to touch the opposite scapula. This tests the abduction and external rotation and tests adduction and internal rotation. Press on the scapula to prevent scapular motion with one hand and raise the patient's arm with the other. This compresses the greater tuberosity of the humerus against the acromion. Flex the patient's shoulder and elbow to 90 degrees with the palm facing down. Then with one hand on the forearm and one on the arm, rotate the arm internally. This compresses the greater tuberosity against the supraspinatus tendon and coracoacromial ligament. Ask the patient to fully abduct the arm to shoulder level up to 90 degrees and lower it slowly. Note that abduction above shoulder level from 90 degrees to 120 reflects the action of the deltoid muscle. Elevate the arms to 90 degrees and internally rotate the arms with the thumbs pointing downward, as if emptying a can. Ask the patient to resist as you place downward pressure on the arms. Support the patient's forearm with your opposite hand so that the elbow is flexed to about 70 degrees. Identify the medial and lateral epicondyles and the olecranon process of the ulna. Note any nodules or swelling. Now palpate the olecranon process and press over the epicondyles for tenderness. Palpate the grooves between the epicondyles and the olecranon process where the synovium is most easily examined. Normally the synomia and the olecranon brucae are not palpable. Inspect the palmar and dorsal surface of the wrist and hand carefully for swelling over the joints or signs of trauma. Note any deformities of the wrist, hand or finger bones as well as any angulation. Observe the contour of the palm, namely the thenar and hypothenar. Note any thickening of the flexor tendons and flexor contractures in the fingers. Palpate the 8 carpal bones lying distal to the wrist joint and then each of the 5 metacarpal and the proximal, middle and the distal phalanges. Now examine the fingers and thumb. Palpate the medial and lateral aspects of each IP joint between your thumbs and index finger, again checking for swelling, bony enlargement or any tenderness. Coming to the wrist movement flexion. With palms down, point your fingers towards the floor. Now the extension. With the palms down, point your fingers towards the ceiling. Adduction. With palms down, bring your fingers towards the midline. Abduction. With the palms down, bring your fingers away from the midline. Test hand grip strength by asking the patient to grasp your second and third fingers. This test function of wrist joints, the finger flexors and the intrinsic muscles and joints of the hand. By tapping lightly over the course of the medial nerve in the carpal tunnel. Ask the patient to press the backs of both hands together to form right angles. These maneuvers compress the median nerve. Bend your thumb across the palm of your hand and bend your fingers down over your thumb. Then you bend your wrist towards your little finger. Ask the patient to raise the thumb straight up as you apply downward resistance. The knee should be extended at heel strike and flexed at all other phases of swing and stance. Check the alignment and contours of the knee. Observe any atrophy of the quadriceps muscles. Inspect for any loss of normal hollows around the patella, a sign of swelling in the knee joint and suprapatellar pouch. Note any other swelling in or around the knee. Note any irregular bony ridges along the joint margins. Examine for the medial and lateral meniscus. Palpate the medial meniscus and examine for the medial and lateral joint compartments MCL and LCL. Palpate the medial and lateral joint compartments of the tibofemoral joint with the knee flexed on the examining table to approximately 90 degrees medially. Now examine the medial compartment. Move your thumbs upward to palpate the medial femoral condyle. Examine for the lateral compartment and the patellofemoral compartment. Place the left hand above the knee and apply pressure on the suprapatellar pouch, displacing or milking fluid downward. Stroke downward on the medial aspect of the knee and apply pressure to force fluid into the lateral area. Tap the knee just behind the lateral margin of the patella with the right hand. Place the thumb and index finger of your right hand on each side of the patella. With the left hand, compress the suprapatellar pouch against the femur. Palpate for fluid ejection or balling into spaces next to patella under your right thumb and index finger. Push the patella sharply against the femur. Watch for fluid returning to the suprapatellar pouch. With the patient supine, grasp the heel and flex the knee. Cup your other hand over the knee joint with fingers and thumb along the mid-joint line. From the heel, externally rotate the lower leg, then push on the lateral side to apply a valgus stress on the medial side of the joint. At the same time, slowly extend the lower leg in external rotation. With the patient supine and the knee slightly flexed, move the thigh about 30 degrees laterally to the side of the table. Place one hand against the lateral knee to stabilize the femur and the other hand around the medial ankle. Push medially against the knee and pull laterally at the ankle to open the knee joint on the medial side. With the thigh and knee in the same position, change your position so that you can place one hand against the medial surface of the knee and other around the lateral ankle. Push laterally against the knee and pull medially at the ankle to open the knee joint on the lateral side. With the patient supine, hips flexed and knees flexed to 90 degrees and feet flat on the table, cup your hands around the knee with the thumb on the medial and lateral joint line and the fingers on the medial and lateral insertions of the hamstrings. Draw the tibia forward and observe if it slides forward from under the femur. Compare the degree of forward movement with that of the opposite knee. Place the knee in 15 degrees of flexion and external rotation. Grasp the distal femur on the lateral side with one hand and the proximal tibia on the medial side with the other. With the thumb of the tibial hand on the joint line, simultaneously pull the tibia forward and femur back. Estimate the degree of forward exertion. Position the patient and place your hands in the positions described for the anterior drawer test. Push the tibia posteriorly and observe the degree of backward movement in the femur.